So, hi, my name's Dr. Adi Kale. I'm a radiologist and doctoral researcher and medical algorithmic audit lead at UHB. And we're looking at AI safety monitoring in the real world and adverse event reporting for AI as a medical device. So I've been very fortunate to be working with a multidisciplinary and fantastic team covering various different roles. My specific role has been firstly to think about how we evaluate AI as a medical device on the ground in the post-market surveillance phase, and we've been using what's called the Medical Algorithmic Audit Framework to evaluate these technologies in the post-market surveillance space. I think the main inspiration for evaluating Oxipit ChestLink is this whole chest X-ray backlog, which is an NHS-wide problem. We know that there's a huge workforce gap. There's a mismatch between supply and demand, and it's very difficult to ensure that patients receive timely reports for a whole host of scans that are being completed. And often chest X-rays, which are some of the most routinely done type of imaging, some chest X-rays can be deprioritized, and patients might be waiting a number of days to actually have the report finalized and sent back to the referring physician. So Oxipit ChestLink actually provides a pretty unique solution to automate some of those scans and try and reduce workload that would otherwise fall on reporting radiologists and radiographers. To my knowledge, this has been the largest retrospective study for high confidence normal reporting in chest X-rays, and I'm really excited to kind of see what the next steps are and also see where this then takes Oxipit ChestLink. In terms of some high-level findings, we've managed to curate a data set of nearly 200,000 scans, which is one of the largest retrospective data sets for reporting of high confidence normals. We found that there were just over 140,000 chest X-rays within scope for ChestLink processing, and out of those there were just over 63,000 normal studies that could be reported by ChestLink. Within that, just under 15,000 of these were actually determined to be high confidence normals, and therefore a report was generated by Oxipit ChestLink. And when we look at reporting fractions, that actually amounts to 23.4% of all of the normal scans that were contained within that data set of 200,000. And if we think of all studies, we're actually managing to reduce 10.5% of the workload each calendar year. And so I think those are some pretty significant numbers. I think that has the ability to significantly reduce the radiology department's workload. And then there's further adjustments to be made there to try and target which scans we're actually focusing on and actually maximize the benefit. We were both surprised and impressed at the sensitivity of the algorithm. So actually from these 141,000 scans that were within scope, there was a discordance rate of only 4%. And following consultant radiologist review of all of these scans, that discordance rate dropped to 1%. And so what we're finding is that Oxipit ChestLink is only missing a maximum of 1% of cases that otherwise should be deemed abnormal. So I guess we were both surprised and impressed. I think Oxipit ChestLink could impact both reporting time and workflow efficiency. If we look at workflow efficiency, as I mentioned, I think that if you have that triage module, in addition to the high confidence normal reporting, you're going to be able to move the reporting staff, so the radiologists and radiographers, and really utilize or maximize their time and efforts looking at scans that might have some pathology. Obviously, that there still needs to be some discussions around how that works for training and keeping your eye in for normals, but I think that is a discussion that we are having at the moment. And then in terms of time saving, I think that there is definitely fairly significant gains to be had in time saving, because at the moment I don't think any NHS trusts are able to report every single chest x-ray that's done in a day. Whether or not that will then translate into significantly improved patient outcomes is a different question, and that's probably something that needs further evidence. But in theory, yes, I do think that the prioritization module could be of significant benefit. So in terms of what clinical evaluation metrics we're focusing on, it's very difficult to provide an accurate benchmark, and this is not just specific to Oxipit ChestLink. This is kind of across the NHS and the kind of whole AI as medical device implementation conversation. The approach that we took in this case was to look at a historical data set. So we curated our data set from 2018, which meant that all of the patients who'd been imaged should have had a report written already, and also we would know what the final outcome for that patient was. So did they have a follow-up scan? When was that follow-up scan? What kind of modality was it? We'd also know kind of what happened to that patient in the end in terms of clinical outcomes, because we can look at the electronic patient records. And so what we were looking at for this instance was obviously the reporting rates that I just mentioned, but we were also looking at the characteristics of the discrepancies. So if there was a discrepancy between the Oxipit ChestLink report and the report that was written by UHB staff back in 2018, then we would actually do more of a deep dive into those cases, have them reviewed again by consultant UHB, consultant radiologists, and we're currently in the process of now modeling what would have happened if ChestLink were to miss a certain diagnosis. Conducting this study has been particularly interesting. I would call myself a bit of a skeptic optimist when it comes to AI implementation. So I think that implementing AI needs to be done right. It needs to be done with robust validation, which is what we're trying to do in UHB. And I think, yes, I would definitely, I think that the findings definitely warrant further work with Oxipit. I think that jumping straight into a kind of a full-scale active deployment might be a step too far at this point, but I do see that in the future. So I think what we would want to do is have a shadow mode deployment for a certain period of time, see how that works, do a little bit of qualitative work with the department, and actually I'm more optimistic in this case that actually that probably will translate into a real world deployment. And so those are my thoughts at the moment. I think I'm pretty encouraged by the findings from the retrospective review, and I'd be really interested in seeing how it performed in a shadow mode, and again, pretty optimistic about the fact that it would translate into the real world.